Can someone unmute themselves and let me know if I am audible?
Yes, ma'am.
Yes,
Okay.
yes, I can hear you.
Thank you so much. Welcome to the Neurosurgical Case Room. We are going to do the approaches to lateral ventricles today. This is going to be an orientation session, and afterwards, we will be covering individual ventricular approaches in the later sessions this week. I really hope you all have taken a look at the anatomical session. Let's start with the anatomy nonetheless. Since we've covered this is going to be rapid fire, right? We know we have 5 parts of the lateral ventricle: the frontal horn, the body, and the atrium, the occipital horn, and the temporal horn. Now, why were these important? And we spent quite a lot of time in terms of doing their boundaries, memorizing the surrounding structures, etc., etc. Because the surgical approaches are going to be very different for each of the part of the lateral ventricle. Usually, these are 5 parts, but they can be grouped in 3 different surgical approaches. Usually, the approaches for frontal horn and body are grouped together. The occipital horn is approached separately, the temporal horn is approached separately, and the atrium has certain separate approaches. You cannot approach all of these from the same place. We know that because we know how different the anatomy is. Let me clear. So this is a frontal horn extending deep into the frontal lobe. This would be the body. We have the atrium here. This is the posterior horn or the occipital horn, and then the temporal horn, which runs into the temporal lobe. Now, this is a superimposed illustration of the lateral ventricles onto the cortex so that we get an idea. If you look at it from a surgeon's point of view, you can see that this is the frontal horn here, and this can be accessible easily from the corridor above. Then we have the body. We know that it can also be approached from a corridor here. The problem is partly atrium and then the occipital horn, because they sit in relatively eloquent regions. Let's look at the overlying cortices so that we can discuss it. Oof. Okay. We discussed quite a lot while doing the anatomy. This exact slide, if you all remember the discussion, you would remember that this is the inferior frontal gyrus here, and underneath it, which was the part that was deep to it? Anybody?
Insula.
No. If we go deep, yes, there would be insula, but if I go deep
Frontal
directly,
horn.
frontal horn, that's right. Whoever said that, you are right. For the frontal horn, if we know it sits right under the inferior frontal sulcus. Then we also discussed that the pre and the post central gyrus, underneath them, there is the body. We are going to see the cut sections again. Underneath them, there is the body. This was the supramarginal gyrus and the angular gyrus, this region here. Let me change the color. So this is the supramarginal gyrus and the angular gyrus. Deep to it, we knew that there was atrium, right? This is the temporal lobe. Deep to the temporal lobe, we knew there was temporal horn. Why is the cortical anatomy important? Because if we are choosing any transcortical approach, we need to know what is the safe trajectory. Please mute yourself, Dr. Norbert. Okay. Coming back, we know that the inferior frontal gyrus is an eloquent region, especially on the dominant side. So obviously that is ruled out. The other closest option would be somewhere around here, the middle frontal gyrus. This can be used as an axis trajectory. Apart from that, if you come back, you can also see that the supramarginal gyrus and the angular gyrus, this is also eloquent region. This is inferior parietal lobule. Hence, you cannot use this region to access atrium as well. So the only option is to go via, let me change the color, via the superior parietal lobule or the precuneus approach, because you cannot go via the inferior parietal lobule. Then coming back to the temporal horn, I'm just giving you examples as to why the topographical and the cortical anatomy is so important. This is the superior temporal gyrus, and we know that this is also eloquent. Why? We have the primary auditory cortex here. We also have some portion of the vernix area here. Therefore, we know that we cannot use this gyrus as a corridor for the temporal horn. We would need to use the middle temporal gyrus, which is here. So anatomically, all the structures of the lateral ventricle, they lie within the eloquent regions, and we have to find non-eloquent regions to access them. Are we all clear so far?
Yes, ma'am.
Okay, moving on. So yes, under once we retract the inferior frontal gyrus, we are going to see the insula, the short gyri, and the long gyri. Under the short gyri, we are going to find the frontal horn. Under the long gyri, more or less, we are going to find the body of the lateral ventricle. These are the cut sections, and now you can see that the almost entire frontal lobe has been taken away. The only thing they have left is the pre and the post central gyri, both of these here. You can see somewhere around here, this is going to be the inferior frontal gyrus, which has been taken away. Deep to it, there will be frontal horn here. This is the frontal horn. Let me mark if it is not clear on your slides. Can you see this brief outline? The one that I just highlighted? This is the frontal horn. You can see its extension into the inferior frontal gyri. But it is also accessible from the middle frontal gyrus. When we go slightly back, we know that the body is extending under these two gyri. If we also cut them, we are going to have a very good look at the body of the lateral ventricle. They have very conveniently dissected away the supramarginal gyrus here. Because they have taken it away, you can see the atrium. Am I making sense?
Yes, ma'am.
Okay,
Yes.
moving on. Now, since we are on a very beautiful slide, let's take another look here. You can see the medial surface of the cerebral hemisphere as well. The medial surface or the precuneus is also used as an alternate corridor to reach the body if you don't want to go via the traditional transcallosal approaches. But you can now see what is the relationship. Let's move on. This is another dissection, a beautiful, beautiful dissection that also shows the middle temporal gyrus has been taken away here. Mark. This was the middle temporal gyrus that has been taken away, and you can now glimpse within the temporal horn. So for temporal horn, you are either going to go via the middle temporal gyrus, which is the most straightforward trajectory. The other option is to open up the sylvian fissure here, to open up the sylvian fissure and go via the insula, the trans-sylvian transinsular route. That is also one option. But middle temporal gyrus is something which is very, very straightforward. Let's move. It's a similar dissection, and you can now see the frontal horn, also see the temporal horn deep to the middle temporal gyrus. The atrium has been completely exposed here. the entire lateral ventricle has been exposed here, apart from the posterior horn. As you can see the atrium, deep to the supramarginal gyrus, which has been dissected away. You can see the continuation of body underneath these, the pre and the post central gyri, and you can also see the frontal horn, which was underneath the inferior frontal gyrus, but it is also accessible from the superior surface via the middle frontal gyrus. You can access via the superior frontal gyrus as well, but we avoid it. Can somebody let me know why? Am I audible?
Yes, may you repeat the question? Sorry.
Sorry?
I was saying, may you repeat the question? I missed the question part. So.
Okay. I was saying that why am I emphasizing the middle frontal gyrus? Why not the superior frontal gyrus?
I think because the frontal eye fields are located there.
That's right, because it is an eloquent region as well. There are frontal eye fields. We do not want to traverse through them. Hence, we sort of avoid the superior frontal gyrus. There are surgeons who have used it because it has the supplementary frontal eye fields, not the actual ones. The actual ones are slightly posterior to this. So there are surgeons who have used superior frontal gyrus, but middle frontal still stays superior in terms of access and safety. Apart from that, in fact, let's move to the next slide. Okay, so this is another beautiful cadaveric dissection that we have seen before. What do you see here? What is the most prominent structure apart from the cortices?
Corpus callosum.
Corpus
That's right.
callosum.
We discussed corpus callosum very thoroughly while we were doing the lateral ventricular anatomy. Why? Because this single most structure is making up a lot of boundaries of a lot of parts of the lateral ventricle. The structure, or the part that we are most concerned about is the roof. Obviously, it's very visible in this sagittal section. You can see that it is making up the roof of most of the lateral ventricle. Since it is making the roof, and we also know it crosses the midline, and there is a normal natural corridor, which is the interhemispheric fissure right in the midline. Corpus callosum is also a very good source of access for both the anterior lesions and the posterior lesions. You can go via here, and you can also go via here. There can be an interior transcallosal approach, there can be a posterior transcallosal approach, depending on where the lesion is located. But what happens if we sacrifice or compromise the corpus callosum? What are the risk factors?
Patient who develop a disconnection syndrome, which can manifest in many ways depending on the part that would have been severed during the procedure. But it's mainly disconnection syndromes, broad.
That's right, because corpus callosum is the major pathway which is connecting both the hemispheres. If you it's like blocking the main highway of a country. If you end up injuring the corpus callosum, the body sort of loses connection between both the hemispheres. Apart from that, akinetic mutism is going to be a problem. Memory, speech, there are going to be a myriad of symptoms. So what we get to do is we do make a small incision in the corpus callosum, but we limit its dimensions. It should stay between 1 to 2 mm. We are going to discuss the callosal approaches separately. What I want to do is give an orientation about when to select what. But in comparison with the transcortical approaches, because you can see how much distance, how much distance you will have to travel if you had to go via a transcortical approach. All of this gray matter and then the white matter and all the tracts within it, you will be putting at risk, right? Apart from that, there would be a huge risk of seizures because this is not a natural corridor. In comparison, transcallosal approaches would always be a natural corridor because the only structure that you would need to actually transect would be corpus callosum itself. The entire cortex is preserved. We will come back to this discussion later on. Let's move on. I'm going to give you a small list. It's not small by any measure, but still it's something. We have divided these approaches. Obviously, we won't be able to do all of them within our limited sessions. Let's see how much we can do. And if there's any specific approach that you would want me to cover, let me know, because I did the ETV first because a few people requested me separately to cover the ETV first. For frontal horn and body, the easiest, the straightforward approach is interhemispheric transcallosal approach. It's a natural corridor. If you go through it, you make a very small incision in the anterior corpus callosum, and voila, you'll end up in the lateral ventricle directly. Apart from that, anterior transcortical approach is an option, mainly via the middle frontal gyrus. And then there is transfrontal transsulcal approach. What do I mean by transfrontal transsulcal? This is a gyrus. This one is a sulcus. This is a gyrus. And this one is a sulcus again. You get the gist, so on and so forth. Now, if I want to, in fact, let me draw something here. Assuming that this is your ventricle here underneath, and the white line that I'm going to draw is my surgical trajectory. And this is the target lesion, this brown mass. What happens is if I cannot approach a lesion via the interhemispheric corridor for whatever reasons, for size, for laterality, etc., what happens is I am now left with two choices. I either can go transcortical or I can go transsulcal. Both have their own cons and pros. When I'm going transcortical, I'm going to breach all of this gray matter and the white matter in order to reach here. The cortical injury is going to be longer. The tract is going to be longer. The trajectory is also longer. And I risk creating a bigger epileptogenic focus. Am I clear so far?
Yes, ma'am.
If I choose to go transsulcal, which is this approach here, if I choose to go via this, then what ends up happening? I bypass all of this depth of the gray matter. And now I am starting directly here. So this is a smaller version of, sort of interhemispheric approach, because interhemispheric is a normal corridor. It's a natural corridor. In the same way, this is also a natural corridor. So if we go down it, we have lesser chances of injuring the gray matter. The problem is that right under the depth, there are vessels. And it's really difficult to maneuver these vessels and create a trajectory which is big enough to reach this target. Am I making sense? Is this clear, or does anybody have any questions?
Okay, it's clear. Yeah.
Okay. Let everyone else. So if we are going transsulcally, we bypass a lot of the gray matter and we start directly right at the end. So the trajectory is, the distance is shorter, but then there are vessels in the depth of the sulcus. That can be a problem sometimes. For the atrium, we can have the posterior transcallosal approach, which is also called the splenal approach. We can go via parieto-occipital transcortical approach through superior parietal lobule or the parieto-occipital cortex. This is usually from the medial surface of the hemisphere. Superior parietal lobule is non-eloquent relatively in comparison with the inferior parietal lobule. What was the content of the inferior parietal lobule?
Vernix.
Vernix.
Sorry?
Vernix area, ma'am.
Oh yeah, vernix. I sort of made up any other word. Yes, there is vernix area. There's supramarginal gyrus and there's angular gyrus here.
Angular gyrus.
Yes, we want to avoid this. This is eloquent. Superior parietal lobule is relatively non-eloquent. You can sacrifice it. Apart from that, you can also use the precuneus approach. Precuneus is the medial surface of the same thing. Then we have the transsulcal approach and transtemporal or subtemporal approach. This is relatively difficult, lesser used, but it also exists as a corridor. So I wanted to keep it in the list. Temporal horn has separate approaches. Transsylvian transinsula is one of them. Middle temporal gyrus is one of them. Then we have the subtemporal approach via.
And the transsulcal approach for
Yes.
atrium. Transsulcal approach for atrium. Can you?
Yes, there is transsulcal approach for atrium. You are going to go via the intraparietal sulcus. You will have to mark it, and then you're going to follow the trajectory for the sulcus. We are going to discuss all these approaches individually. Today is just an overview in what approaches for which region and when to choose which one. We are going to come back to all of this in the later sessions. For temporal horn, the easiest one is middle temporal. Also the most used one, the workhorse. The other one is Transylvian transinsular approach. Subtemporal approach can be used for the temporal horn, but I personally feel it creates a longer trajectory. And then we have the occipital horn approaches. These are the trickiest ones because we are dealing with the occipital cortex, which is the visual cortex. So we have two options. If the lesion is lateral, we can go via occipital transcortical approach. If the lesion is medial, near to the midline, we can go via the interhemispheric into occipital approach. This is a rough illustration. You can see the anterior transcallosal and the anterior transcortical. Both are going to approach from the same side. Posterior transcortical and transcallosal. For occipital, we need direct access. And then for the temporal, if we are going to need the middle temporal gyrus and hence a temporal craniotomy marked here. Temporal horn can also be reached via a modified pterional approach. How do we select which one? This is a small algorithm, and I think you're all familiar with it once you see the patient. The first question we need to ask is whether the lateral ventricle is enlarged. If there is hydrocephalus, then the pathway changes. We now have two options. You can either go transcortical or you can either go endoscopically. How do you decide? If it is a huge lesion, a big lesion, for example, a choroid plexus papilloma or carcinoma, which is huge, and you know it would be really difficult to get the entire lesion out with only the endoscopic approach, then transcortical corridor is going to be your best bet, given that there is hydrocephalus or enlarged ventricle. If there is no hydro, if the ventricles are normal sized, what do? We go to the natural corridor, which exists nonetheless. We go via the transcallosal corridor, especially if the lesion is in the midline, bilateral, and closer access, not very lateralized. What do I mean by lateralized? This is the lateral ventricle, assuming any lesion which is on one side, extremely on the one side, is going to be difficult via a midline approach, which ultimately transcallosal corridor is. You can, I'm not saying that it's not possible, you can. The problem is the trajectory is going to be difficult in comparison with the transcortical corridor, where you can go directly. Are we clear on the algorithm? If there's hydro, we go via transcortical if the lesion is large and lateralized. If the lesion is a small or we need a biopsy, then we can go via endoscope. If the lateral ventricle is not enlarged, there is no hydro, then the ideal approach is going to be a transcallosal corridor. So when do we use transcallosal? Do we have a volunteer?
Midline bilateral lesions, ma'am.
That's right. If there is a bilateral lesion, if there's a midline lesion, and especially in the body, the anterior portion of the body, and even some of the third ventricle lesions, they are accessible via the transcallosal corridor. We use them when there is no hydro, there is small or normal sized ventricles. And why do we do that? We have discussed that throughout the session. Obviously, it is a natural corridor. There's very limited transaction of important structures involved, like the corpus callosum. We spare all of the cortex. Therefore, we avoid the risk of post-op epilepsy. The problem is disconnection syndrome, obviously, and speech disorders, memory disorders, transkinetic mutism, etc. What is somebody saying in the... Okay, Dr. Juan, I hope I'm pronouncing your name right. Anterior or posterior would depend on which portion we are accessing. Right now, we are only comparing the transcallosal versus transcortical approaches. This is a very easy illustration that shows what I'm trying to say. You are going to save all of this cortex because this is a natural corridor. Once you reach here, you can make a small incision in the corpus callosum and land up directly inside the lateral ventricle. For lateral ventricle, this is one of the most beautiful approaches you can possibly have. When do we use transcortical corridor? Take a look at this lesion. This is small. If this was huge, for example, I'm sure you all would have seen the cases of choroid plexus carcinoma or papilloma. You know how big they tend to get. If there is a huge lesion and we are limited in the amount of callosotomy we can make, if we all know we have to keep it between 1 to 2 centimeters, right? So this becomes a limiting factor. This is our window through which we are peeking within the lateral ventricle. If our entire window is 2 centimeters and there is a huge lesion that cannot be accessed completely, transcortical approach becomes a better option given that there is enlarged ventricles. Why are we relying on enlarged ventricles though? Any volunteers?
Sorry, what's the question?
The question is, why are we relying on the enlarged ventricles or hydrocephalus for transcortical approaches?
I think because due to thin parenchyma. So, I mean, thin.
So what ends up happening is, if there's hydro or if the ventricles are enlarged, they tend to thin the cortical mantle. Because the cortical mantle is relatively thinned out, it reduces the distance. It also reduces the surgical trajectory, and we are going to damage lesser cortex in comparison with if there was no hydrocephalus. Because the normal size of ventricles is very, very small, it will be very difficult to locate without hydro. Let me move. Endoscopic corridors are beautiful when the lesion is small and you only need a biopsy or, for example, a CSF diversion procedure. But there is hydrocephalus. For these lesions, endoscopic corridor is a beautiful, beautiful option because it is minimally invasive. It will not leave a lot of morbidity in the patient. The problem is the trajectory is going to be very limited. The working angles are difficult. The learning curve is very, very steep. Not every neurosurgeon is a good neuroendoscopic surgeon. The learning curve is very steep. You need to work in a specialized center which is regularly doing neuroendoscopic approaches to do it, apart from the basic ones, which is the E2V or colloid cyst. They are considered the basic lesions. Apart from that, if you're planning to remove the tumors via a neuroendoscopic corridor, the learning curve is going to be obviously very, very steep. So this was our orientation, and this session will be continued tomorrow, inshallah, where we will cover the anterior transcortical and anterior transcallosal approaches, inshallah ta'ala. Does anyone have any questions? No questions today? Thank you so much. That's okay, that's a wrap for today. I'll leave the link to the recording on the WhatsApp group. Thank you so much, everyone. Thank you, Dr. Yusra. That's a wrap.